Hello, today I'm going to present to you Module 2 of TAVR Fundamentals, Optimizing the Procedure. Here are my disclosures. This module's objectives is to understand step by step on how TAVR is performed, and also to acquire an overview of the Sapien 3 Ultra and Evolute valve deployments. First, we need to look at access, and you can use CT analysis to do a meticulous review of the access site potential challenges, including leofemoral artery calcification or dissections or any other pathology such as tortuosity. At the same time, you can see here that you can look at the access site fluoroscopy on the CT software to determine where is the optimal puncture site, as I have shown here. So first, in terms of access pearls, identify the non-main and main access sites and puncture location on CT, as I shown earlier. You want to match the target puncture sites identified on CT with Fluoro. You always want to use micropuncture kit for access, plus or minus ultrasound guidance. You want to watch for femoral artery calcium and location so that you only have an anterior puncture, if possible. And you want to have the needle entry angle should not be too steep. You want to avoid risk of catheter kinking when you do your catheter exchanges. And finally, your needle entry should be parallel to the artery, and a lateral medial angulation will risk kinking the catheter or sheath and a risk of vascular injury. So let me show you this same figure that I showed earlier. So where would you access this artery in terms of main and non-main? So you can see here in this case, both sides have some iliac artery calcification. This one had maybe a focal pathology here on the common iliac artery. But you can see that both femoral arteries are relatively clean. There is some left on the right common femoral artery. There's some calcification on the posterior medial wall, but it's clean here. So I would probably pick the left femoral access, the main access site. So you can see these are the site that I pick on CT. So I'm going to try to match it on fluoroscopy at the time of access. The key is to access with the needle parallel to the vessel. So you can see that the bolded white arrow is where I would aim in terms of direction of the needle with the micropuncture kit. You don't want to access with the needle on either laterally or medially on either side of the vessel. So I put an X across, so do not do that because that will potentially risk kinking the catheter and the access wire such that you can cause a vascular injury at the access site. So here's an example here. You can see that this is the right main access of a patient. We can see the access point is where the needle just have come across with the wire. This patient had an up and over wire for the main access site already. So you can see the needle was parallel to the vessel. And when you see the left anterior puncture, you can see that here is right at the access site that I want to target using micropuncture. And non-angiographically is an anterior stick. So in terms of pre-closing with the Proglide, you need to understand you need to pre-dilate the trap with a French dilator so to avoid fat or soft tissue getting stuck to the device. You want to use a longer stiff wire rather than a short JY. There's tortuosity in the iliac arteries for exchanges, so that way you avoid injuring the vessel wall as you advance the Proglide device. You want to make sure you have brisk back bleeding at the side port, such that you confirm that you are actually in the lumen before you deploy the foot plate. Follow the Proglide foot plate location after you deploy it or before, so that you match the puncture location. You're not too deep and you're not outside the artery. And finally, you want to find ways to identify the pair of sutures such that you keep away from access site but avoid excessive tension to inadvertently lock the sutures. Here's a picture of the Proglide. This is the lever that you deploy the foot plate, as you shown here in the top left corner. And you can see that on the right panel, on the fluoroscopy, you can actually see where you are on your foot plate. You should be at the access point so that it's not too deep and not outside that access point to avoid foot plate related injury to the vessel. And you can follow save that at the time of the access. Now, in terms of angulation and orientation, it's important because depending on the vessel characteristic and diameter, you want to be able to deploy the first Proglide and the second Proglide in slightly different orientation to reinforce the arteriotomy closure. So first, you want to rotate the lever at perhaps at 10 o'clock in a clean, large vessel, and then you rotate the second Proglide and deploy the lever at 2 o'clock. Now, it also depends on the caliber vessel. As I mentioned before, it's a large vessel. I would say over 6 millimeter, you can do 10 to 2. But imagine if you have a smaller vessel, if you do the same deployment, you could potentially pinch the vessel and make it stenotic. So for smaller vessel, maybe 11 to 1 o'clock orientation may be sufficient. Now, if you have lateral wall calcium, you certainly don't want to deploy the Proglide close to the calcium. It might fail where the foot plate is. So you might have to choose rather than 11 to 1 or 10 to 2, you might want to do 12 and 2 on that side. Contralateral, opposite, if you have a medial wall calcium, you want to have the Proglide orientation, the lever, and the opposite. So maybe it's a 10 to 12 o'clock. So try to face away that area if you have the wall calcium in the way. If there's a big sheath insertion, you want to use a stiff wire, either supercore, M+ or Lundquist, if absolutely necessary for very tortuous vessel. But you need to have the stiffest wire to straighten out the tortuous calcified segment. The sheath to dilator transition point may get hung up in the soft tissue, so you have to be very careful when you insert the big sheath. And you can corkscrew the sheath gently into the artery rather than just pushing it by force. You want to advance the sheath under fluoroscopy directly and track its advancement to the dominant aorta so that you don't cause any inadvertent iliofemoral injury. And you want to secure the sheath to the skin with a suture if you need to. So, and then you want to advance the sheath. And if it's small calcified vessel, consider balloon angioplasty in tightest segment, or do intravascular lithotripsy, such as shockwave. And you want to use serial dilators plus or minus lubricant to precondition the vessel as well to make the tracking seamlessly. This is a paper we published recently using balloon post-dilatation, pre-dilatation of the expandable sheath to facilitate the Sapien 3 transfemoral TAVR, especially in severely calcified vasculature. I encourage you to read our case series because what we found is that when you pre-balloon the E-sheath with these balloon sizes, it really reduces the push force of the commander system inside the E-sheath to avoid vascular injury or getting hung up, the device getting hung up inside the E-sheath because you cannot track across the vessel. The other thing what we need to look at is identifying the fluoroscopic angles ahead of time. And this is a classic paper from Marcus Castle's group looking at 3-cut view on how to get the coplanar view for balloon expandable valve deployment and regular aorta and horizontal aorta. So I encourage you to read that. And in terms of the self-expanding valve, we now typically would use the cusp overlap technique to identify the true depth in TAVR deployment. So you can see on the left panel, the cusp overlap view, the non-coronary cusp is really sprayed out, identify at the lowest level, which is also far away from the conduction system, the membrane septum, which is shown here in the light blue, versus the free cusp view or the LAO, where your non-coronary cusp is much sprayed open, so it's harder to determine the true depth at that implant angle. So this is how we do the cusp overlap view without the CT, in case you cannot undergo a CT analysis because the patient advanced renal failure. You can see this is a free cusp view, and you put your pigtail and another catheter wire in the right cusp and the left cusp, and just overlap between the two. And there is your cusp overlap view, and you can then reposition the pigtail onto the non-coronary cusp to continue with the valve implantation. So here's an example. Pigtail on the right cusp, you then track the left cusp where it is, overlay the two. You can see that here is kind of a near cusp overlap view. So it's very simple. In terms of crossing the valve, this is a nice paper from the Marcus Castle's group that just published this year on using the free cusp view on how to cross the valve with different catheters. Again, I will encourage you to read that. We typically use a strict terminal glide wire. With the native aortic valve, typically use AL2 or sometimes AL1, depending on the root size, and the 3 cusp of LAO view. With the prosthetic aortic valve, we typically use an AL1 or AL2 catheter and an RAO or non-parallax view. In terms of wire and catheter exchanges in the left ventricle, you need to make sure that once you cross, you go to the RAO view and advance the catheter in the LV by gently spinning it while you maintain the wire control. So how you do that is typically have your ring and baby finger pinning the glide wire while you use a thumb and index and middle finger on the hub on the right hand, and then the left hand onto the catheter at the sheath hub to gently advance the catheter over the wire. You want to avoid sudden catheter or wire motion and risk LV perforation. And then you exchange the straight glide wire with the long J, clock the catheter towards the LV apex as the JY exits the catheter. And afterwards, the assistant walks the catheter out to maintain the J-wire in the LV while operator one holds the sheath and pin the J-wire. The pigtails then advance over the J-wire into the LV, but the pigtail curve should be facing up, not down, for optimal stiff wire placement. And when you exchange the J-wire with the stiff wire, your right hand advances the stiff wire while your left thumb, index, and middle finger at the pigtail hub, and slowly retract the pigtail as you advance the stiff wire towards the LV apex. You try to maintain the pre-curve of the stiff wire facing up to avoid the tail of the stiff wire caught in the trabeculate. And this ensures the maximal coaxiality of the valve positioning and deployment. So here's an example here on the left side. Your curve, you see here, faces up. Good coaxial deployment. You can see the delivery system here. You can see that here, this is the curve faces up, that faces down rather, and this is bad because the valve will swing upward as you deploy the valve, so try not to do that. And you can see that here, we now have the balloon pre-dilatation. And you again remind you, the balloon expandable valve have different dimensions. You want to be aware of that, and you want to know the sizing chart intimately well to know which valve to size. In terms of my personal sizing strategy of the Sapien 3 Ultra, you want to consider percentage oversizing to both annular and LVOT areas. What's the presence, location, severity, annular LVOT calcium, risk of coronary obstruction, is it bicuspid or tricuspid aortic valve, and also feasibility of redo TAVR in younger patients. In general, we aim for less than 10 to 15% oversize, and you can certainly undersize in high-risk anatomies. If you oversize by 10 to 15%, especially to LVOT, you can certainly remove volume to avoid root injury. If you can also undersize and not much calcium, you can add volume to improve expansion and sealing. There's really no hard and fast rule, but you really based on experience and feel against resistance. You want to aim for inflation pressure no greater than 7 atmosphere on the syringe. And there's no pressure gauge on the 29S3. So you want to make sure you attach the atrial gauge to help guide the pressure-based inflation if you need it. So here's an example CT scan showing the annular and LVOT anatomy and the dimensions. You can see there is an LVOT and annular calcium along the long axis of the annulus. And then you can also see that there's a hockey puck view here showing the trileaflet aortic valve. We also do a 1 millimeter slice from the base of the aortic root all the way up to around 10 millimeters to show the distribution and the severity of the calcification at the base, because typically this is where the annular injury and rupture may occur. Of course, you look at the sinotubular junction and the sinus valve dimensions as shown here. We also superimpose a virtual valve of the balloon expandable valve that you plan to implant to assess the risk of coronary obstruction, and particularly in this area with the left main view, and also any chunk of calcium at the base that might potentially risk annular injury. This is also the right coronary view. You can see on the left side of this panel to show the risk of right coronary obstruction, which is relatively uncommon. Now, we recently published a paper looking at Sapien 3 Ultra, whether you can actually undersize it more than beyond the IFU compared to patients who actually had a normally sized anatomy. And we found that there's really no difference in mortality, stroke, PVL, and hemodynamics. However, you can see that here, if you have the undersized but well-expanded valve, you might be able to facilitate redo TAVR versus a larger valve where you might potentially be less feasible for redo TAVR. So in terms of avoiding aortic root rupture or injury, we typically would true size or undersize a balloon expandable valve to avoid that, and you can always overexpand this without potential risk of PVL or transvalvular AR. So in terms of positioning, the Sapien 3 Ultra and the Sapien 3 foreshortened from the ventricular side. And so we typically look at the top of the S3 frame relative to adjacent landmarks to guide positioning, such as STJ calcium or left main stent, and if parallax is present on the S3 frame. If there's no parallax, then you can pretty much valve will end up as expected. However, if there's parallax on the valve frame at the time of positioning, the valve may end up higher or more aortic than expected. Now, people talk about the Lucent line deployment to try to get more aortic implant. However, this is present only if there's no parallax on the S3 frame at the positioning. And there's really no way to control this if you're going to deploy this at the coplanar free cusp view. So Typically, we would like to aim for higher or aortic implant, especially when the LVOT is smaller than the annulus. You want to avoid conduction issues. If the LVOT is bigger than the annulus, then you want to implant more aortic to maximize the sealing against the aortic valve leaflets, because you're not going to be able to seal against the LVOT because it is larger. Now, in terms of annular LVOT calcium, you want to seal against the leaflet to avoid the aortic root injury. Typically, I would say you position the balloon marker 2 to 4 millimeters above the annular plane, so that is the bottom of the marker on the free cusp view, and you will need to account for the Sapien fit foreshortening based on a number of factors, including the presence of parallax, percentage oversizing to the annulus, leaflet calcium severity, and balloon inflation volume. So here's an example of number of Sapien 3 Ultra valve positioning, and I want to demystify this whole Lucent line technique. So on the left side of the screen, you can see that here the Lucent line is not there because there is parallax on the valve frame at the time of positioning. So as a result of that, you're going to have a parallax on the final deployment. Now, these are all performed at the conventional 3 cups coplanar view. So clearly, you cannot rely on the Lucent line technique on this deployment because you don't have one because of the parallax on the valve frame. Now, in the middle box panel, the 2 different cases, you can see that there is no parallax on the Sapien 3 valve at the positioning. So you do see that Lucent line at the inflow area right here, meaning there's a section of the valve frame when you crimp that you see that the wider opening and more clear Lucent line, and you can see that here as well. Now, when that happens, there are 2 possibilities. One is that when the valve is fully deployed, as you've seen here, there is no parallax on the valve frame. So essentially, you can use that Lucent line to guide the final deployment into positioning more aortic so that you can have maximal foreshortening and aortic implantation. As you see, there's no parallax on the valve frame. Now, look at the right 2 cases here. The top and the bottom both have Lucent lines. You can see that there's no parallax on the valve frame at the time of the positioning. You can see that here. But when you fully expand the Sapien 3, look at this. The valve frame certainly has parallax on both. So in this case, you have to be considering other factors that you might still end up more aortic than you think, because even though you have the Lucent line trying to go more aortic already, that parallax would mean that your valve is canted right to the native annulus, because here you're still at the 3 cusp coplanar view. And so your valve is going to be a little bit offset with one side more aortic than the other. So again, because of this, the Lucent line, in my opinion, is not an accurate guidance and reference point for a more aortic deployment. What we typically look at is top of the valve, based on the percentage oversizing, degree of calcification, inflation volume, to determine how much the inflow foreshorten and your target implant depth. So here's the example of a Sapien 3 deployment. You can see there is certainly a Lucent line there because there's no parallax on the valve frame. You can see as the valve is deployed in this particular case, the valve frame is fully expanded without parallax. And you can see that here, the valve is actually quite aortic implant, despite the Lucent line being slightly below the annular plane. In terms of self-expanding valve, you certainly need to know all these dimensions in terms of avoiding coronary obstruction, and also optimizing commercial alignment and coronary access. This is the sizing chart of the Evolute valve platform. And we now know that by inserting the delivery system with flush port at 3 o'clock, facing away from the operator, you should track the delivery system nicely with the hat marker at the outer curve at the time of the crossing the arch, such that when you are crossing to the annulus at the cusp overlap view, it should show you at the center front. And when you deploy the valve in the final cusp overlap view to assess the commissural alignment, the seat paddle should be facing the right side of the screen on fluoroscopy. And that can show you that you have good commissural orientation. So here's an example case, the Evolute FX case of an 88-year-old female, frail on home oxygen, certainly extreme surgical risk for TAVR. And you can see that in this particular case, the CT shows the annulus is quite small, 63.6 millimeter by perimeter, 13.2% oversized, and then a smaller LVOT with larger oversized relative to a 23 millimeter FX valve. Sinus valsalva are quite sufficient, 25 millimeter bigger. You can see that here the coronary anatomy looks favorable, and access is relatively straightforward with a pretty favorable root angle. There's also no aortic tortuosity either. So what we plan to do is to do a 23 FX. There's no PPAV because there's not much leaflet calcium there. And of course, we'll insert the flush port at 3 o'clock and do the implantation based on cusp overlap view. So here's the two views here. That's the free cusp coplanar view. Is the cusp overlap view, as you shown earlier, how to get these two views very quickly without even CT reference. And you can see that here the head marker tracks outer curve from the descending aorta to the annulus very nicely. No issue at all in terms of the trackability of this particular device. And you can see here, we'll use the Safari stiff wire. Now, here's what you do not want to do. So you can see the right side of the screen here, the FX catheter is pretty coaxial and centered against the native annulus. That is the ideal coaxial deployment at the cusp overlap view, because you're not going to be going too deeply on one side or the other. Now look at the left side. This is what you not want to do. You do not want to have, this is simulating the blue rectangle represent the delivery catheter. You do not want to be too much on the outer curve. Why? Because as the valves start to flower and make annular contact, you're going to be swinging upward and perhaps miss the left cusp or maybe too high in the left cusp. In the middle section, this is the opposite. If your delivery catheter is too much in the inner curve, in that case, when the valve is flowering and swinging to the left cusp, you may end up too deep on the left cusp, and so you have an asymmetric annular contact, and so as a result, you might have a suboptimal implant depth on release. So what we try to do is try to make the deployment as symmetric as possible by centering the delivery system, and you can do that by optimizing wire and catheter management. So how do you do this? So first of all, if you are in this situation on the left side where you have the rectangle or the delivery catheter too much in the outer curve, well, the easiest way is to have the operator one pull back the delivery catheter towards more center. You don't need to really do anything with the wire. Now, if you have too much of the inner curve, though, what you want to do is to have the operator 2 or 3 who manage the wire to push the wire so that the catheter will be more into the outer curve. And then what you want to do is then you perhaps might need to adjust the catheter depth to optimize the initial annular contact. And of course, what you want to do is to aim for symmetric flowering and annular contact. So initial deployment here, you can see that here, in the cusp overlap view, and you want to do a control pacing when the evolut flowers to get annular contact. And you can see that at 80% deployment, you want to do the cusp overlap view. With the evolut FX, what you want is to have 2 out of 3 dots at the annular plane, which means you're at the 3 millimeter mark or slightly below if necessary. And you want to make sure that you have a 2-1 relationship to determine commissural alignment. Once you swing to the LAO view, you can see that here, if you're happy with the depth, you pull back a stiff wire to near the nose cone, and which is slow release with rapid pacing of 150 to 180 beats per minute to minimize the valve pivot on release. The nice thing about the evolut system with the FX is that it's very symmetric on annular contact and flowering. You can see that on release here. So you can see here now that the C-tabs located in the curve of the ascending aorta on the right side of the screen, and the cusp overlap view, you really see the C-tab at the right side of the screen really just completely not visible to you, and that is how you know that you have good commissural alignment. And in fact, by seeing these 2 views on the free cusp and cusp overlap view, you can actually use Fluoro CT coordination that I previously published to determine the commissural orientation. You can see that here, this is well aligned to the native commissures. So in summary, I would say TAVR procedures are reproducible if meticulous techniques are followed. And you saw some of the standard techniques that we do here. The Sapien 3 Ultra, you really want to aim for an aortic implant, but account for the patient's anatomy and the Lucent line absent or present to optimize device positioning. And I would go for slow inflation. And with evolut, you want to insert the flush for 3 o'clock for optimal commissural alignment. and aim for symmetric device flowering and implant depth, shallower than the septal length, and typically would be around 2 to 3 millimeters at the non-coronary cusp. So I'd like to thank you very much for your attention.